Okay.
This is Dr. Karen Luxford. I'm Director of Patient-Based Care at the Clinical Excellence Commission. I wanted to welcome you all to this first of a series of webinars by the International Society for Quality in Healthcare and the Clinical Excellence Commission as a joint initiative. We've been collaborating on some regional educational activities, and this is the first of our webinars. So welcome everybody. We have people from right across Australia and indeed the world, and we know that this is a very topical subject. If you are enrolled for the ISQua Fellowship, please note that you'll earn points by participating in this webinar this morning. And if you're not a fellow yet, you might want to consider joining up to the ISQua Fellowship, and that's available on their website. This event will also be recorded this morning so that it will be available more broadly for people via the ISQua and CEC websites after today. I wanted to introduce to you this morning Associate Professor Ian Scott. Ian is the Director of Internal Medicine and Clinical Epidemiology at the Princess Alexandra Hospital in Queensland, in the city of Brisbane, and he's also at the University of Queensland. Ian is the author of a controversial article called Using HSMRs to Assess Quality of Care, Proceed with Extreme Caution. We're going to hear from Ian this morning, and then we're going to have an opportunity to take some questions from you via the chat facility on the webinar. So please send your questions in. I will then ask those questions to Ian at the end of his presentation. We may not get to everyone's questions, but please do send questions in. We want this to be an interactive session. And I'll hand over now to you, Ian.
Thanks very much, Karen. Good morning, everybody. I'm very pleased that you have such an interest in this topic. It certainly is controversial. I think it is still an issue that many people debate as to the pros and cons. And I guess I'm going to give you my sort of spin on HSMR, but realise that we're all in this together trying to improve quality and safety of patient care. And this is perhaps one tool that may be helpful, but I feel it has some limitations. So is it useful as a marker of quality and safety? I think the first thing we should do, though, just before we move on, is to just define what a HSMR is. I'm sure many of you will be familiar with the term, but for those who aren't, I think we should give a definition. And the HSMR, or the Hospital Standardised Mortality Ratio, is a ratio of the observed number of deaths seen in the hospital over a period of time compared to the expected number of deaths through the same period, multiplied by 100 usually to give a percentage value. Now, the observed number of deaths is easy. That's simply the number of deaths that occur in your hospital, and that's tallied up. What's not so easy is to work out, well, what's the expected number of deaths? How many deaths would your hospital expect to see if you were giving good quality care, safe patient care? This is a statistical tool, and you need to bear in mind that herein lies some of the limitations of the HSMR. The expected number of deaths is calculated using a logistic regression model, and that's derived from a reference population. And in most cases, it's the numbers, it's all hospital admissions that are admitted to hospitals throughout a particular jurisdiction, whether it be a state or in perhaps the entire country. And that regression model adjusts for factors that affect the risk in hospital death. Clearly, people are older, people have severe illnesses, people have marked comorbidities, other chronic diseases, patients who have complicated hospital length of stay, which is usually long, and people who are admitted urgently as emergencies. These clearly are going to increase your risk of dying, no matter how good the quality of care is. So this model adjusts for these factors that impact on mortality. In most cases, this ratio, the HSMR, involves assigning a probability of dying to each patient that you look at within a particular hospital who've received a diagnosis or undergone a procedure. And usually that's one diagnosis or procedure within about 65 conditions or procedures that account for the majority of all hospital deaths, about 80% or more. Some tools there are different. They look at all 100% hospital deaths and all diagnoses and procedures, but it makes the calculation of the model more difficult doing so. So people tend to compromise and go for the most common conditions and procedures that account for the majority of deaths. So the HSMR, if you have a value of 100, means that your hospital's observed mortality rate equals that expected based on your case mix in regards to the reference population. If your HSMR is greater than 100, then you have a higher than expected mortality rate, and if it's less than 100, you have a lower than expected mortality rate. Now, the key function of the HSMR is that if you have an excess number of deaths, HSMR greater than 100, then people may get concerned that is this due to the fact that your hospital is providing less than optimal care? What we need to think about, though, are what may be the alternative explanations for HSMR that's greater than 100. And it may be related to how the expected number of deaths has been calculated using the regression model, or there may be lots of other confounders, lots of other factors not related to quality of care that may impact on that ratio. And that's what we need, I think, to have a look at and be mindful of when we're interpreting HSMR. HSMR is presented in different formats, but probably the most common two is the caterpillar plot, which is the upper panel, which for each hospital lists the HSMR as a point estimate with then 95% confidence intervals around that. They're the little bars. But more commonly now is the funnel plot, which is the lower panel, where we plot the HSMR against the expected number of deaths. The point of this is that clearly as you have more events, you have less random variation. So this funnel starts as very wide when you have a small number of deaths. For example, in a small hospital where you may only have 1 or 2 deaths per month, versus a large hospital such as my own where you may have scores of deaths per month. So clearly, as you have less random variation, there's less spread of the values. And what we see here are 95% and 99.5% confidence limits, which again helps to define the precision of the HSMR such that values that lie outside those control limits are statistical outliers. In other words, these values are beyond what we would expect as acceptable random variation for the ratio. And that becomes, as I mentioned, less of a problem as you have more and more events. So this funnel plot narrows as we go further out to the right. As you can see, this funnel plot allows very quickly to look at a number of different hospitals and see which are well above the HSMR and which are well below. And this is how the graph is used to help identify hospitals which seem to be doing very well, perhaps, in terms of quality care, and those potentially that may have some problems and warrant further investigation. Now, there's many attractions of the HSMR, and that's really why it's become so popular in various quarters. As you can see, hopefully, I've now made it easy for you to conceptualize, and administrators and clinicians can easily get their head around this. The indicator can be used to compare not only hospitals within, but also across different jurisdictions. So at a national or state level, it can be quite helpful to work out regional differences. Certainly the HSMR has attracted a lot of use in various countries. In the UK, as you're probably aware, the Dr. Foster unit has regular reports, annual reports that feature the HSMR, and also gives even monthly reports to the Department of Health. In Canada, the Commission for Initiative Health Improvement also uses HSMR, and Sweden and Netherlands are other countries that now have used it as a routinely collected statistic. It's been used to gauge also the success of several large-scale safety campaigns in various countries. In the US, the Institute of Healthcare Improvement has used it, and Safe Care Now, the campaign in Canada, also adopted it. As you know, in November 2009 here in Australia, Australian Health Ministers endorsed the HSMR as one of 7 key indicators of hospital-level performance. And my hospital website in Australia, but also in Canada and the UK, now regularly report HSMR for individual hospitals. So I don't think this ratio is going to go away. It's not going to disappear. And certainly I don't feel it's my job today to try to rid Australia of the HSMR. What I'm here, though, is to try to ensure that we interpret it correctly. I think we need to be aware of some of the limitations of HSMR. First of all, HSMR does not include deaths occurring after discharge or deaths that may be related to suboptimal outpatient care. People have argued that we should be looking at all deaths, not only in hospital, but for 30 days after discharge, because there may be some quality problems that were occurred involving patients in hospital that didn't manifest as death, but they then subsequently came to grief later. So people have argued that we should be looking at 30 days, not just in hospital. That clearly requires a fair bit of data linkage to actually link deaths in the community with patient episodes of care in hospital. Also, HSMR does not detect morbidity or complications. It's purely a death indicator, and we know that many suboptimal instances of care give rise to complications, give rise to events that don't actually kill patients, but nevertheless cause some significant morbidity. And also, HSMR does not detect non-clinical outcomes. Clearly, again, it's a death indicator, so it has no bearing on patient complaints or dissatisfaction, and certainly won't be a marker of waste or inefficient clinical practices, which also are very important in these days of constrained healthcare budgets. It also has limited predictive value. I think this is an important point that often is really not given its due emphasis. What we're really talking about when we're looking at a death indicator is that we want to know how many of these deaths were potentially preventable, how many may have been prevented by getting better care. And it's interesting that when people have looked at this based on detailed review of deaths using case notes and also talking to patients, carers, or sorry, not the patient, the patient has died, but to carers and to the staff that's looking after that patient, the percentage of all deaths in hospital that are really preventable is pretty fixed at about 5 to 6%. There's been a couple of studies, and most recently by Hogan, which looks at this in some detail. It's about 5 to 6% of all deaths. Bear in mind that too, the percentage of deaths in most hospitals is of the order between 5 and 10%. So it's a relatively infrequent event, and therefore, of a relatively infrequent event, only a very small percentage, about 5 to 6%, is actually related to potentially suboptimal care. So that puts a bit of a problem, because if we're using HSMR as a screening test, and that's really how many people use it, then we need to be aware that the prevalence of preventable deaths really is very small. And as a result, even a very good screening test is going to have lots of false positives. And this has been indicated in a number of studies. If preventable deaths were at least 15%, which clearly is not, that's almost more than twofold what we actually observed. But if we, for argument's sake, preventable deaths were at least 15%, then the positive predictive value, that is, that if you have a HSMR that is outside the 2.5% confidence limit, if your HSMR is in that order, the chance, though, that your hospital actually has a true preventable death problem is only about 30%, less than 1 in 3. If we come back to 6%, which is what the studies have actually observed, 6% preventable deaths, and the chance that your HSMR really reflects poor quality care, that is preventable deaths, is now dropped to 8%. So only 8 out of 100 of HSMRs that are in excess of 100 actually relate to potentially preventable deaths. As a result, hospitals identified as performing poorly 10 out of 11 times would not be performing poorly once you actually looked at case notes and did a detailed review of that hospital's clinical processes. Equally, 10 out of 11 poorly performing hospitals would not actually be identified by a HSMR that was in excess of 100 or outside an acceptable range for all hospitals being considered. So we have a problem in terms of the predictive value. When you see a HSMR that's an outlier, either excess or less than expected, it doesn't necessarily mean, in fact, it's a very poor chance that the hospital actually is associated with preventable deaths. The next limitation is utility. HSMR is a hospital-wide indicator, and for large hospitals, as a result, the ratio really doesn't provide you with actionable data. You don't know where to start. If you have a HSMR that's in excess of 100 and would suggest that you may have a problem, if you're an outlier statistically, where do you go looking to see where the problems are? In my institution, when we have more than 35 separate departments, where would you start? So it doesn't actually target the clinical microsystems of the hospital practice, where we can actually drill down and find if there are particular units or particular departments that have a problem. And this is an example in some of the instances in the UK where, for example, at Leeds Infirmary or at Bristol, it wasn't the entire hospital that was at fault. It was only specific units within that hospital that was a problem. If you have a hospital that has a low HSMR, in other words, indicating that perhaps you're running exemplary quality of care, studies have shown, though, that individual diagnoses or the care of individual specific conditions within the hospital may still be less than optimal and have a higher than expected mortality, as I've just mentioned with the examples of Bristol and Leeds. Also, while mortality is important, other patient-important outcomes are also not currently assessed. So HSMR should not be seen as the screening tool and as the only measure that we should look at, or the one that we should give highest priority to. We should look at other measures of quality of care, which I'll talk about in a minute. Also, finally, the HSMR is a relative measure. It's a measure of an individual hospital in relation to a reference population. We need to bear in mind, therefore, that no matter how good the quality of care may be in hospitals, there will always be hospitals who rate higher than average. We can't all be average. Some of us must be above and some of us must be below average. That's simply how statistics work. That's the distribution of values. So, of course, your hospital may have a higher than, may have a HSMR greater than 100. Does it necessarily mean that you're providing poor quality care? It's just that every hospital now is doing exceptionally well, but someone still has to be an outlier. So really, I think it comes down to my feeling, being involved in this field now the last few years, that HSMRs, you either love them or hate them. Hate, perhaps a strong word, but nevertheless, I have some concerns with them. The proponents would argue that there have been a number of case studies, and the most recent one, the most high-profile one, would be Mid-Staffordshire in the UK. This hospital was identified because it clearly had a high HSMR. It was out of the ordinary, out of the average. And with that, people were then able to drill down, and subsequently then, with a number of inquiries, revealed just how scandalous the care was at that hospital. They would argue, therefore, that the HSMR acts as a flag for further investigation. And the proponents do argue that they are not saying that if you have an elevated HSMR, you must have poor quality care. They're simply saying this could be a flag, you may have a problem, and it requires further investigation. My response to this, though, is that the Mid-Staffordshire really was just good luck. The HSMR was elevated, but then again, it was in a number of other institutions as well. And I think that, in a sense, people using HSMR were able to relate this to a hospital that clearly was providing very poor quality of care. And anecdotally, people only needed to walk into Mid-Staffordshire and spend a few hours there and sense that this was a hospital in crisis. So HSMR was elevated, there's no doubt, but I would argue that the poor standards of care in this institution were well known to people within the institution already, even before HSMR was being measured, but they were prevented from actually doing anything about it. The critics, and I guess I'm one, mention that there are technical shortcomings of measures, which I think I just outlined. Also, there's a lack of evidence for a definite relationship between reported variation in HSMR and the quality of care. There have been a number of studies now that have looked at detailed case reviews in hospitals with an elevated HSMR and found that really the quality of care for high volume diagnoses such as pneumonia, heart failure, myocardial infarction, hip fracture, that the care in relation to good evidence-based practice was very good, and that there were other reasons why the HSMR was elevated, unrelated to the quality of care. We need to be mindful of this because clearly we don't want to unfairly blame or shame institutions because their HSMR tends to be somewhat high or just outside what we would regard as statistical range. And certainly if, as I mentioned, the HSMR has a low positive predictive value, in other words, you may have an elevated HSMR but not have a quality of care problem, I think we would do a disservice to the institution and undermine the morale of its staff if that was then publicly reported and they were made to feel that they were inferior institutions. So I think in closing, outcome data by itself is not enough. Yes, HSMR and other measures based on routinely collected data deserve looking at, but we need to keep them in context. We need to place them in the right order. Outcome data are useful research and monitoring within an organisation. I would argue that are going to use HSMR, then use it as an internal benchmark within individual institutions rather than use them as comparative across institutions. Those who wish to improve care for patients and not penalise doctors and managers, I think, should concentrate on direct measurement of adherence to clinical and managerial standards. So actually, we should always be looking at what we actually do for patients in hospital at the level of the clinical microsystem. That's going to be our best measure and arbitrator of poor quality care. So, any questions? Thank you very much.
Thank you for that, Ian, and I'm sure that people will be wanting to send in questions via the chat line. While we're waiting for those to come in, I wondered, you talked a little minute ago about some possible alternatives. I was wondering if you could just tell us a little bit about what they might be.
Thanks, Anne. Well, I think there are other things that we can do. First of all, if you want to use HSMR, perhaps the best way of using it would be to look at specific, high volume, well-defined clinical diagnoses for which we have evidence-based care bundles. What I mean by that is, for example, let's look at, in your hospital, acute coronary syndrome. Now, that's a very specific diagnosis. There's very little coding problem when it comes to acute coronary syndrome and myocardial infarction. They're reasonably common. They're certainly potentially lethal. And we also have very good evidence-based practice. We know what we should do to treat these patients based on multiple clinical trials. So in that context, HSMR within an institution can then be useful to monitor over time whether we're seeing excess deaths, which are more likely, therefore, perhaps to be related to poor quality care, if we've taken account of any other confounders like poor coding, etc. But I like the HSMR in this instance because it then, the technical limitations that we talked about previously, become less of a problem. So that's one way of looking at things. Another way, though, is to mandate chart review of all in-hospital deaths. And my institution does this, and I think quite a number of institutions now do this as well. That within an individual department, all deaths need to be looked at by a clinical team that includes not only the doctor looking after that particular patient, but his peers. And that also the team includes not only doctors, but nurses, allied health and others, so that each case is then looked at critically and impartially to see whether there may have been a quality of care problem. And that care may not have been related to an individual's actions, but to the actions of the team. And I think this is useful, this is important, because at the end of the day, our care now is very multidisciplinary, team-based. So it's, again, not the right thing to try to apportion blame for a particular individual if there has been some problems with the care. So I think mandated chart review for hospital deaths, and perhaps also we should look at those that occur within 2 weeks of discharge as well, should be included, as we currently do in my own institution. Certainly our experience has been that this has been very helpful and has helped to identify problems with those systems and individual performance. The third thing is an ongoing audit or registry-based review of evidence-based clinical processes for high-volume, high-risk conditions. And this again comes back to perhaps conditions like acute coronary syndrome, heart failure, etc., where we know what we should do and that we should keep a register of these patients, perhaps not every patient, but a representative sample, and monitor our processes, record those and review those at regular intervals as either snapshot audits or ongoing registries. The fourth thing we can do is look at adverse event screening and targeted case review for all those incidents which are more likely to affect a quality of care problem. We know that, for example, if patients are suddenly transferred to intensive care because they've gone into crisis or decompensated, patients who develop catheter-related bacteremias, bloodstream infections, patients who develop venous thromboembolism in hospital, patients who are subjected to serious medication errors, for example. All these things are definitely iatrogenic problems which we can prevent, and therefore if we see these instances in terms of diagnostic coding, for example, or the end of the discharge summary, then again we should drill down and have a close look and see what happens here. And finally, a tool that I think is perhaps also more useful than HSMR, and that's risk-adjusted statistical process control methods, or real-time flagging of unfavourable trends for specific diagnoses. Some of you may be familiar that in Queensland, we use the variable life adjusted display, or VLAD. And we have found this to be certainly quite helpful, because even with small numbers of patients or even small numbers of deaths or events, we can see whether there's an unfavourable trend developing, that we would ask our member institutions then to drill down and have a closer look and see whether there may be a quality of care problem. The advantage of this is that you can look at what's happening just within the last few months, whereas with HSMR, often you're relying on data that's been collected over the last 12 months or even 2 years. And obviously, the smaller the hospital, the longer back you have to go to accumulate a sufficient number of deaths to really make any conclusions. The VLAD using SPC, I think, is a more accurate tool and provides us with real-time flagging where we can drill down and have a closer look. So I think these are the issues, these are the methods that are worth looking at in trying to identify suboptimal care.
Thanks very much, Ian. The questions are starting to flow in. We have a question from Anne Morgan about the impact of transferring patients to palliative care, and I imagine to hospice care, and the impact that has on your case mix and then subsequently on the HSMR calculation.
Yes, that's a very good question, and this has bedeviled, I think, a lot of HSMR studies in the past. Certainly the Canadians are very aware of it. I think the UK now, the Dr. Foster unit, is now making distinctions between patients who are palliative versus patients who are not palliative. It clearly has an impact. There's absolutely no doubt. The studies have shown in Canada that HSMRs that were well in excess of 100 dropped below 80 virtually within a matter of weeks. Now, clearly that can't be related to quality of care. No quality improving intervention is going to work that quickly. And when they looked at it, what actually happened was just changing coding, that a palliative care code was introduced that then took out a large number of patients whose death was expected, and therefore the HSMR went down. Now, you may argue, well, why wasn't that picked up with the regression model? If you've got a terminal condition, surely that should be taken account of. Well, not necessarily, because many conditions can cause people to become terminal, not just cancer. It may be severe chronic obstructive lung disease, it may be severe heart failure, it may be severe neurological disease. So there's lots of conditions that can render a person palliative or terminal. So there's no way you can pick it up with a diagnostic stage. You've actually got to bring a classification to say that this patient is now receiving palliative care. And I think in any HSMR calculations, we should remove patients who are palliative, because clearly that's going to skew the results.
Thanks, Ian. A similar issue, or a related issue raised by Paul Russell, is around documentation, and if you're better at documenting expected death or end of life phase, how that in turn impacts on your HSMR.
Well, again, it comes back to the same issue. That's right. That if you're now being very obsessive with your coding, that is making sure that clearly, as I mentioned, the risk adjustment model used in the HSMR takes into account comorbidities, for example. So if you're not coding all the relevant comorbidities in your patient, then your patient will be less likely to die, according to the regression model. And therefore, if they do die, then your hospital starts to look like an outlier. So I think, certainly in our institution, I'm sure many, with HSMR now being introduced, we're now pretty obsessive in trying to make sure that all our coding is accurate, comprehensive, includes all the relevant comorbidities that may impact on a person's life expectancy. And also, I think there's been a look at the actual primary discharge diagnosis itself, in the sense that did this patient just have cellulitis, or did they have cellulitis with systemic inflammatory reaction response syndrome, for example. I'm not saying that there's deliberate gaming going on, but certainly there's attention now to ensure that we really do capture the severity of a patient's illness, and we capture all the comorbidities and other clinical characteristics that may elevate their risk of dying.
Thanks, Ian. Just a question in closing. Given that HSMR is flagged for introduction for national reporting within Australia, I just wondered if you could reflect on some of the recent media fallout in the UK. And there was a comment about the NHS having the worst death rate in the West. But it was interesting that Professor Sir Brian Jarman's comment in relation to that was that HSMRs are no more than a trigger. I wondered if you could just in closing reflect on the use internally by boards and by clinical governance units in comparison with external reporting.
Yes, well, certainly within our institution, for example, we do look at HSMR, a regular indicator that our critical incident and mortality review committee look at. I think, fortunately, I've been able to educate that committee to be just mindful, to get to knee-jerk reaction to a HSMR that may suddenly just fall outside what may be the expected range. I think as long as people are educated as to the limitations of HSMR, then I don't have a problem people using it as an internal monitor of hospital performance. Where I do have problems is clearly where we have these statistics, particularly in relation to hospitals, across jurisdictions, being reported in media, which is then uninformed. People then go off and make these wild estimates, saying that the system is in crisis and have these huge numbers of preventable deaths. I did read that report, and in particular, I was interested in David Spiegelhalter's commentary in relation to that, and I would recommend that everyone read Dr. Spiegelhalter's review on that, because he's a statistician, and as he said, some of the reporting and some of the calculations that are being made would make a statistician weak. So I think that we always are going to have this issue where uninformed commentary, particularly sensationalist commentary by the media, is always going to be something we're going to deal with. But we should just try to ignore it, put it to one side, and focus internally on the HSMR, particularly in relation to, as I said, high volume specific diagnoses and looking at particular departments and units rather than perhaps the hospital as a whole.
Thank you very much, Ian. That draws our webinar to a close. Thank you indeed, everybody, for your questions. And thank you to Ian Scott for your time today. I also wanted to thank James Nicholson and also to Karen Lucas at the Brisbane end for your technical assistance. And as I said, the webinar will be recorded. It will be more widely available. And to let you know that our next session for the joint ISQua CEC webinars will be on Thursday, the 24th of October. We have Dr. Susan Frampton from the US organisation Planetree with us, and we'll be talking about patient engagement. So thank you, everybody, for joining us today, and I hope the rest of your day is a good one. Thank you.